Okay, hello everyone. We're going to start with today's session. It's going to be on the brain, and more importantly, we're going to go over the functional anatomy, the human homunculus and the human homunculus, and also a little bit about the different arteries with our questions and answers. So we're going to start with the scalp here. So the scalp is composed firstly of the skin, connective tissue, which is quite dense, and aponeuroses, loose connective tissue, and a periosteum. You also have these blood vessels which perforate into the dense connective tissue, but they're only present in the connective tissue layer, whereas the aponeuroses has the venous drainage. And there's an easy way to remember this. It's called scalp, so that's how I remember it. And basically when you have a cut in the skin here or in the connective tissue, like you get hit there with an object like a stone or a brick, and you hit the aponeuroses, the muscles in the front of the forehead and at the back will pull in opposite directions, and this will open up the blood vessels, which causes a lot of bleeding. So this is why when you hit your scalp, you get a lot of bleeding, and it's because of these blood vessels in the connective tissue layer. Now you also have venous, that's quite deeper. These generally don't tend to bleed as much, but the reason for the large amount of bleeding is because you have these blood vessels in the connective tissue area. So next we're going to go over the bones of the skull, and they're quite simple here. We have the frontal bone, we've got the parietal bone, temporal bone, and the sphenoid wing of the sphenoid bone. So that's the skull itself, occipital bone in the back. And then we also, if we cut through the front here, we have the base of the skull bones. That's your maxilla, that's your zygomatic bone, your orbital, and all these small bones. We'll go over them a bit more in depth later. Now, the area of interest here is something called the Pterion. So it's where the four bones, the frontal bone, the parietal bone, and the temporal bone and the sphenoid, it's where they all come together. And what you have through here is an artery. So you have an artery which goes like this, and it branches. You have two arteries like in this way, which supply everything. So you get supply here, and you have supply there. Now, the area here called the Pterion, which is encompassed by all these areas, it's this here. I'll do that in a different color because that's not very visible. So this area here is a weak spot. Now this is the weakest part of the skull, and the reason is because all these areas here, that's where they fuse together. Now you have the anterior branch of the middle meningeal artery flowing right through there. Now if you have the weakest part of the skull next to an artery, you can imagine that if you get hit in the head quite hard, imagine trauma, so like a baseball bat, if you're assaulted or if you fall, you can get a fracture here because it's the weakest part, and these bones here can cause an injury to the artery. Now what does this mean? It's a vital artery, it's very thin coverage, and if it gets hit, you'll have bleeds, you'll have haematomas. And this is like an anatomical view of the here. So this is the Pterion here, it's this region where the frontal bone, parietal, and the temporal bone and the squamous part of the temporal bone specifically meet together. And also the sphenoid here. Now if you get a hit here, that just bleeds out, and that's an acute emergency. Here is another picture, so this is the artery coming up top and then branching offwards. Once again, if you get hit here, you compromise both blood supply to the brain, and also you start creating a hematoma, which we'll get to later, which can cause compression in different parts of the brain, causing damage, causing herniation of the brain. So key takeaway is that you have the weakest spot is the Pterion, you have the middle meningeal, the anterior branch of the middle meningeal artery going through here, and if it's a weak point with the branch, you get hit there, massive bleed, big problem. Moving onwards. So we're going to go back to the bones of the cranial cavity. This picture is from Teach Me Anatomy, very good website. And so we have the calvarium, which is the sort of the top here. And then we have the cranial base. So those are two different parts of the bone. So this is where the brain sits, right? The calvarium, the cranial part. And this is where you would have your mandible, your sinuses, all the other things. Now, what we have here is the frontal bone in the front with the sinuses there. We have the sphenoid bone right beneath it. Joining these two together is the ethmoid bone. We have parietal bones here. So this is from up. We have the occipital bone in the back, which is where the occipital lobe sits. And then we have our opening. So if you were asked to look at to name the bones in the body, in the brain, you would say 1 frontal bone, 2 parietal bones, because they're on both sides, 2 temporal bones. We have 1 occipital bone, 1 ethmoid bone, and 1 sphenoid. And together they make the enclosure for the brain. Now, what's important here is that we'll do this in a different video, is the course of the cranial nerves. It's very important to understand the bony anatomy because I'd have a good picture of this when you talk about the cranial nerves, because that's where they pass through, and the different foramen and the different sort of processes are key attachment points as well. So we're going to go up to talk about the meninges. So we've talked about meninges in the spinal cord. Now the ones in the skull are a little different. So we have the dura mater still, but there's 2 sort of layers about this. There's an outermost layer, which is, it's tough and fibrous and it's fused to the inside of the skull, and then you also have an inner layer. And the difference between these two is where you have your venous sinuses or your venous drainage. So this is where you will have also your infolding, so your falx cerebri and your tentorium cerebelli. Now it's fused to the part of the skull, that's very important. We also have the arachnoid mater, which contains arachnoid granulations, and these pass through into the dura and they help drain the CSF. Now this is very important, and we'll get back to this when we talk about the ventricles, but the CSF has to course around the brain and then has to be drained to the spinal cord so that it can come back to the blood and be recirculated. Now it lies just beneath the dura, as we can see here, just beneath it, and it's quite thin, and underneath that we have the subarachnoid space. So it's between the pia mater and the arachnoid. It has these fine processes, right, which sort of bridge everything together, and it sort of holds everything here. So we see the arachnoid holding to the pia mater with these little processes. And we can see the infolding, so this is the dural layer here, the infoldings. So we'll have the dura on top, which is part of the skull, and the dura on the bottom, which is part of the meninges. Now in the subarachnoid space, it's a real space, not a potential space, which means it has CSF in there. It also contains many blood vessels, as can be seen here, which supply the brain. So this could be cerebral arteries and cerebral veins. Now, what's also important to talk about in the meninges is their relation towards the skull. So we can see that these are the different blood vessels which are found within the arachnoid. We have these arachnoid granulations. They pass through the dura into the venous sinuses. And what this allows essentially is that CSF can exit the subarachnoid space and enter blood. So you want CSF sort of entering blood. So this is one point of conversion between CSF and the blood. We also have these things called venous sinuses, and they're also found within the meninges, and they drain blood and CSF. And then we also have the blood vessels to the brain, and these are also found in the CSF, in the subarachnoid space. So as you can see, the meninges, their allocation towards different meninges is very important. They help cover the brain, that's one of their functions. They also help these infoldings to increase the surface area of the brain, but also facilitate the drainage of CSF and blood. Now if we go back here, so this is the falx cerebri, so it's the infolding of the dura mater itself. So you can see it looks like a little plastic covering or like a bag over the brain. So these can fold inside of themselves, and they would be called the venous sinuses, because that's where you would have the blood. And here you have the falx cerebri, and here you have the superior sagittal sinus. Okay, so we're going to talk about the lobular divisions now. So this is a cross section here. So we have the frontal lobe, the parietal, occipital, and here would be the temporal lobe, as you can see there. That's part of the cerebrum. Then we have the cerebellum, that's separate. That is not divided into lobes. But when we talk about lobes, we talk about these four. Now the frontal lobe has many different things. It's involved in movement, decision-making, problem-solving, planning. It's the part that's the biggest in us. It's what makes us an intelligent animal. Dolphins, apes, elephants have a larger frontal cortex relative to their brain size. But ours is the largest relative to our body weight and relative to the percentage of brain mass of the total brain. Now the prefrontal cortex, this is your personality expression, your planning of complex cognitive behaviors. This is your complex thinking. Whereas your premotor cortex, that's basically your voluntary muscle movement. That's when you sort of decide to do something, when you decide to contract the muscle. Then we have the primary motor cortex, which is also for voluntary muscle movement. We have the parietal lobe, which has your somatosensory, so this is your sensory information. It has your somatosensory cortex, and it's also used for proprioception. So it gets impulses from all around the brain so that you can know where you are. You can keep your, so it helps communicate with the cerebellum with balance, but it sort of helps orientate you. We move to the occipital lobe. It's in the back, as we remember from our lectures in year 1. The brain, the optic nerves, they cross over and they go all the way back to the occipital lobe. So this is the primary visual cortex, and it receives all the input from the retina and helps with our visual perception. Then we have the temporal lobe. It's on the side. It contains many different things underneath it. You can have your limbic, you have your olfactory cortex, amygdala. That's all under the temporal lobe. But the key areas here are the Wernicke's area, the Broca's area, which are used for language and perception, and then importantly the primary auditory cortex. So the side, because it's close to the ears, if you can think of it that way, is where we have our audio perception. And yeah, so that's our audio perception there. So now we're going to look about the functional areas of the cerebral cortex. So there are a few here. We have number 1, which would be that would be your Broca's area. That's for speech. Number 2, that's your precentral gyrus. That's for motor. Number 3 is postcentral gyrus. And when we talk about the gyrus, it's just the shape of the skull, and it's this thing that they're referring to. So if it's pre, it's motor. Post, it's sensory. And that also marks the division between the parietal and the frontal lobe. Number 4 is something called we have Wernicke's, which is auditory, and number 5, that's the visual cortex over there. So next, I'm going to talk briefly about the basal ganglia. They're quite complex. They're a collection of nuclei, and they're strongly connected to the whole of the brain. So this is your cerebrum, your brainstem, your cerebral cortex, and this interconnectivity allows for the complex actions the brain undertakes. Now they have a lot of functions. So one of them includes to receive input from the cerebral cortex, then to provide output to the motor parts. So this is where if this goes wrong, you get Parkinson's. So everything is slower. So this is the medial ventral groups of nuclei in the thalamus that help enable this. You also have the control of your subconscious, which is very important. So this is like laughing after a joke, swinging arms whilst walking. So this is subconscious contractions that happen in the body that you don't really notice. This is also where when you learn how to sit properly or sit down, This is what your body is trained as a child to do. Then we also initiate and terminate motor processes or cognitive processes. So it's your attention, this is your memory, this is your planning. So as you can see, it's very important. And it's comprised of the following sort of components. We have the subthalamic nucleus, which means it's found beneath the thalamus, which is located here. So that'll be the thalamus. It's subthalamic nucleus right there. We also have, is responsible for glutamate, which is an excitatory neurotransmitter. We have something called substantia nigra because it looks black on, it's a black substance, it looks black on pathology prosections. And this produces dopamine. It's very important because the lack of connections in substantia nigra, or the depletion of the substantia nigra, I should say, causes Parkinson's. Now, let's say you have a vascular accident in this area, right, like a stroke. That can also give you Parkinson-like features and symptoms. So this area is very important. As we said again, it's the control, initiation, and termination of cognitive processes and motor parts. So this is why sometimes Parkinson's people have difficulty initiating movements, or they have repetitive movements, so they can't stop movements. So it's either initiation or termination problems. Then we move on. We have something called the corpus striatum. So it's formed of two key things. It's formed of the lentiform nucleus. So it's formed of something called the lentiform nucleus, and that has two parts, and the caudate nucleus. So the caudate, if you can believe me, it's shaped as a comma. That's what they usually say. It's comma shaped, and it's usually at the bottom. And then we have our other components. So this would be the lentiform nucleus. You would have your putamen and globus pallidus. So globus pallidus is the one that's more closely to the inside. That's the blue one here, and it's more lateral to the thalamus. Whereas the putamen is also lateral to the thalamus, but it's closer to the cerebral cortex. And all of these together form a very intricate network of connections that help facilitate actions for the brain. Now here is a sort of simplified picture of the following. So on top we have our sort of caudate nucleus. We have our putamen, globus pallidus. We have our lateral ventricles, and the third ventricle there, and this is the thalamus. As you can see, it's quite close to the thalamus. Right here, it's not really that visible, but it's close to the thalamus, and it's usually comma-shaped. Together, they're quite important with So think of them as initiating and terminating actions, and they're quite close to the temporal lobe. So we'll talk about the brainstem. The brainstem is very important because it has several important functions, such as breathing and heart rate and all that control and swallowing. So these are life sustaining functions. Therefore, any damage, so you can have a severed, it's like you snap your neck, or you fall and you crash here, it's like an road traffic accident. That can be a problem. That you can have vascular incidents, the pons and midbrain, where the blood vessels follow through. That can be an issue. Or when you have an accident, such as a sudden stop, you might tear some arteries, and therefore that leaks out, and you don't have blood supply, causing ischemic damage. So it's very important. It also has origins for various cranial nerves, which we will get into. So as we know, cranial nerves start from the top of the brain, and they go slowly down the bottom. So starting from the bottom, we'll talk about the medulla oblongata. Think about the medulla as life-sustaining functions. So this is autonomic and involuntary functions. It's your breathing, your heart rate, your blood pressure, your swallowing. So if you have damage here, or it's something that's known as coning, that's where you have lack of breathing, heart rate, and swallowing. It's bad. It's an emergency. Now we also have origins for cranial nerves. This is where their nuclei stand. That's your cranial nerve 8, 9, 10, 11, and 12. So you can think of the medulla oblongata as the final 8 nerves. So it's the cardiovascular center. It regulates your heart and beat and blood vessel diameter. It has a respiratory center combined with the pons, which helps regulate breathing. And you also have the brainstem is responsible for like cough and swallowing and gagging as well. You have many different many different sensory pathways to the brain, such as the glacial nucleus, cuneal nucleus, cochlear nuclei, and vestibular nuclei, which form the cranial nerve 8. So that's the acoustic nerve. So it's responsible for many different functions. Since we have cranial nerves 10 to 12, it's also the vagus nerve. So if you think number 10, vagus, therefore it's going to have to be the heart rate and breathing. And also 11 and 12 and 9, which are responsible for the areas in the mouth and tongue. So it might be due to taste, gustatory nucleus, stuff like that. So yeah, medulla, very important. But long story short, life-sustaining functions and cranial nerves. That's sort of what you need to know. Pons. So pons, once again, it's very similar. You have pontine nuclei which relay functions and they help communication between the two hemispheres. So if you can imagine, you'll have a signal like this that goes through here, gets relayed, and goes to the other half. So it also helps control breathing. So this is the pontine respiratory group along with the medulla. So it controls how we breathe. Take a deep breath in, take a deep breath out. Therefore, very important. It also contains sensory and motor tracts, and it sends messages between the brain and the spinal cord. So we can sort of imagine the spinal cord starts here. It's very important that they interact appropriately. And as you can imagine, just based on the location, the nerves have to go through the pons. Now it also has cranial nerve organs for number 5, number 6, number 7, number 8. So number 8 is shared between the medulla and the pons, and this is just because of the arrangement of the nuclei. So lastly, from the brainstem, we have the midbrain. So it has 2 different parts. You have the superior colliculus and the inferior colliculus. So the superior colliculus, they coordinate movements in response to visual stimuli. So this is your head, eyes, and trunk. So that you hear a noise or instinctively something loud, you immediately turn over towards the noise. This is your superior colliculus. Now, so that's your inferior colliculus. If you hear something, if you see something and you want to turn your body towards it, that's your superior colliculus. And the reason for that is because the inferior colliculus is closer to the pons, which contains cranial nerve 8. So it's closer to the pons, whereas the superior part is closer to cranial nerve 3. So the superior part is closer to cranial nerve 3, whereas the inferior part is closer to cranial nerve 8. And the origins for the cranial nerves is cranial nerve 3 and 4. And these control the eye movement. So that's very important there. As you can see, the relevant anatomy and its function, it relates to the origin of the cranial nerve. So that's sort of the takeaway from this slide. Because you have the muscles of breathing, which are controlled by the vagus nerve and the heart rate as well. So that would be the medulla, hearing, and communication between the two. That's because it's cranial nerve 5, it's centered to the brain. And the top of the midbrain, that's close to the cranial nerve 3 and 4, which controls the eyes. And therefore, that would be response to different stimuli and controlling the eyes and the head. So Diencephalon, so we have 3 structures here. We start with the thalamus. So the thalamus is right there. It maintains your conscience. Sorry, I misspelled that there. It maintains your conscience, and it relays sensory input to the cerebral cortex. It contributes mainly to motor functions, and it's part of the sort of interacts with the basal ganglia. So once the basal ganglia process everything, it goes through the thalamus to the primary motor area. And it also gets stuff from the cerebellum, so it's a communication center for the cerebellum and the cerebral cortex and basal ganglia. So it's like the middleman between everything. and relays almost all sensory input to the cerebral cortex. Anything sensory coming back out has to go through the thalamus. So the contents of the thalamus, it has auditory, somatosensory, and visual signals, and also has the cell bodies of third order neurons. So if you have an ascending pathway going all the way back up, it will have the cell bodies found in the thalamus. Now the hypothalamus is beneath it. It has a lot of functions. These are just some of the 8 ones you can be commonly asked. So it controls and integrates activities of the autonomic nervous system. So this could be anything from temperature, so reaction to increased temperature, reaction to stress, all this sort of stuff. Produces hormones, so this is your releasing hormones, so like your gonadotrophic releasing hormones, inhibitory hormones, oxytocin, and ADH. Also regulates emotion and behavioral patterns with the limbic system, so it communicates with that. There's also once you eat and to feel that you're sate, that's your for your satiety centers, that's for eating, how much you want to eat. Thirst centers, so it motivates you to drink, therefore that's why ADH is produced there as well. It monitors and controls our circadian rhythm, so this is our sleep, and what does that is called the suprachiasmatic nucleus. Basically means it's found above the optic chiasm. Once again, I mentioned thermal control, so this is where you set your internal thermostat. Let's say you have something like a fever, that's all regulated by the hypothalamus. And of course, since it's found so close to the pituitary, it influences the pituitary. Now the epithalamus is found on top of the thalamus. It has 2 main features. It consists of the pineal gland and the habenular nucleus. The pineal gland produces melatonin, which helps with our sleep, whereas the habenular nucleus, it produces olfaction, so it relates with smelling, and it communicates with the relevant cranial nerves and the brain. So overall, 3 parts called the Diencephalon. The reason it's called the Diencephalon is for embryological reasons. It's like the second part of the brain here, so this would be the mesencephalon, that would be the Diencephalon. And we have 3 structures here. Thalamus, it maintains your conscience and communicates with everything else, initiates movement. Hypothalamus, just think master controller of the body and many systems. And then you have your epithalamus, which also contributes with melatonin to sleep and olfaction to smell. Very important, very small structures, very densely packed with neurons. So ventricles. So the ventricles are 4 linked cavities. There you have 2 lateral ones. So this is the first one here. So this is number 1. That's number 1 as well. So that's the 2 lateral ones. We have a 3rd ventricle right there, and then finally a 4th ventricle, if you can sort of believe me, right here. It's not really visible normally, but it will be like behind this area here. Now there are 2 ventricles here. They're usually within the cerebral hemispheres, and they're separated by something called the septum pellucidum. And we have the corpus callosum, which is where all the wires of the brain, basically from one side to the other, pass through. So that's the roof on top. The 3rd ventricle is lateral, is connected to the lateral ones, and it sort of lies in the midline in the forebrain. So this is your Diencephalon. So this would be your thalamus, epithalamus, hypothalamus. It sits just between the 2, and it will be this part here. And there you have the cerebral aqueduct, which was a small little structure which connects the 3rd ventricle to the 4th ventricle. And then finally, the 4th ventricle is found in the brainstem, and it's between the cerebellum and the pons and medulla. Now, the septum pellucidum is a very thin membrane. It just separates the 2, and the reason is because the brain is symmetrical, and that's how it evolves. Now, it's very important for the reason for these hollow structures in the brain is because that's where we have CSF. So these cerebral vesicles contain things called a choroid plexus. Now, the choroid plexus produces CSF. And the CSF goes from the lateral ventricles down to the third ventricle, and then through to the fourth ventricle through the aqueduct. Now afterwards, from the first ventricle, it goes into the subarachnoid space via numerous foramina. And eventually, you have the drainage of the CSF, which is through the arachnoid granulations, and they project into the superior sagittal sinus, which projects into the venous drainage, and that goes to your jugular vein and then into your heart. So we start at the middle of the brain, we go to the third ventricle, aqueduct, fourth ventricle, foramina, arachnoid granulations, and then superior sagittal sinus, and then into the bloodstream. So they're very small, but an important function. Now, what can also happen is that if you have a contusion or any damage here or a brain tumor, you can get blood sometimes leaking in here, and that becomes a huge problem. Or if there's any trauma, you'll have blood in your CSF. So the cerebellum. So the cerebellum is found in the hindbrain area, so it's behind the cerebrum. It's connected to the pons, and it has functions that maintain to do with balance. So it's coordination, equilibrium, so that you don't fall over and trip, muscle tone, and also relates the information between the body muscles and areas of the cerebral cortex. And yeah, that's its main function. It's just as a relay center. Any damage to the cerebellum causes ataxia, so you can't walk properly. Intoxication can also cause long-term alcohol abuse can also cause damage to the cerebellum. Now, I'll briefly talk about the circle of Willis. So this is what it looks like. It's very complicated, but you do not need to know all of the arteries. You have to focus on the key ones. So I would memorize the following because this makes it much easier to draw. You will be asked to draw this in second year, most definitely. This is a very common question, and it's good to know. So we start with the origin arteries. And that's our internal carotid arteries, which go through the neck, and our vertebral arteries, which go through the vertebrae. So those are the first two we draw. So it's our origin arteries. Secondly, we will look into our cerebral arteries. So we have two anterior cerebral arteries going up. So it's the two at the top. Two at the top. We have one middle cerebral artery, which sort of continues from the internal carotid artery. And we have posterior ones, which comes from the posterior part. These all go to the cerebrum. Now the next ones we talk about are the peripheral arteries. So we have something called the pontine arteries. So these are like the squiggly lines. If you think about this as the head, the arms, this is like the ribs of the circle of Willis. If you think of it as a stick man, we have an artery that goes through called the basilar artery, which is an anastomosis of the vertebral arteries together. And we also have our anterior inferior cerebral arteries and our superior cerebral arteries. And these ones go to the cerebellar parts. So once again, basilar pontine arteries, our spinal arteries here, and then our cerebellar arteries. Now you don't really need to include the cerebellar arteries. The main important ones are always the cerebral ones. And then we have to join it all together. We have these communicating arteries. So there's one in the front between the two. That's the anterior communicating artery. And we have some in the back posterior, which join the middle arteries to the posterior cerebral arteries. So that's like a sort of simple way of drawing the circle of Willis. You could do the anterior spinal arteries if you want. Not that important to draw, but usually you'll get the marks for it. But the way I try to think about it is you want to segment it. You have origin arteries, vertebral, internal carotid. You have cerebral arteries, which is 3 of them, front, middle, back. All of them have to be joined together by anterior and posterior communicating arteries. We have our basilar artery, which comes from the joining of the two vertebral arteries. That goes there. pontine, which goes for the pons, and then the cerebellar, which go from the back, and they go with the superior cerebral arteries and anterior inferior cerebral arteries, and then the ones in the back. So we're gonna move on to some questions. So describe the arrangement of meninges in the cranial cavity, a very common question, or they tell you to compare to the cranial with the spinal. So this is what we have a look at. So it's the dura mater endosteal layer, that's part of like the or the periosteal layer, which is part of the skull, meningeal layer of the dura mater, and in between the two we have our superior sagittal sinus and our something called the subdural space because it's beneath the dura. We have our arachnoid mater, yes, and our pia mater. Next question, just as I alluded to, what are the differences between the spinal and cranial meninges? Well, as we said, there's two dural maters, that's the key one, and therefore we have consequences as of that. So the epidural space is a potential space in the cranial cavity, it's between the periosteum and the skull, whereas the epidural space is a real space in the spinal between the dura and the vertebrae. And the fact that it's a real space, the epidural space, is where we can put our epidural anesthesia. It's very important. It also allows us to take CSF. The dura mater is double layered, so we have an inner skull and into the bone. And then we have single layer, which is just suspended in the vertebral canal. So we don't have anything extra there. Subdural space is both potential space in both cases. In the cranial cavity, you get something called a subdural hematoma. In the spine, you can get a similar thing. Arachnoid space is attached to the inner surface of the durans in both cases. Subarachnoid space has CSF, and the pia mater is attached to the CNS, and in spinal it's called denticulate ligaments. Very common question, comes up nearly every year, cranial versus spinal. So yeah, recap, epidural space, potential space here, real space there. Subdural space is present in the cranial, but it's a potential space. Spinal also has a subdural space, but it's much smaller. So intracranial hematomas, so this is an application of the anatomy. So it's all good to know the anatomy, where the stuff is, but if you can sort of go a step further and say, let's say if there's blood pushing on a brain, how does that affect everything? Well, then you're not going to get very far. So we're going to talk about the different intracranial hematomas. This is a very useful picture to remember because we can have an epidural hematoma, subdural hematoma, and an intracerebral. So we start with the epidural hematoma. So this is collection of blood between the cranium and the dura mater. And as you can see, it's pushing into the dural space. And yeah, it's not good. So vulnerable vessels, it's your arteries, and particularly the Pterion, as we learned. So it's the anterior branch of the middle meningeal artery. You can get a fracture in the temporal bone, which lacerates the middle meningeal artery, and you have something called an acute epidural hemorrhage. The source of the bleed is almost always arterial, and therefore if it's arterial, it means it can expand extremely rapidly. And what can you sort of expect in a patient? You'll have rapid deterioration of neurological function. So suddenly they'll be feeling crap, but then a couple of minutes later they'll be completely out of it. So these people are emergencies, and you need to get them to drain the epidural hematoma. Then we have something called a subdural hematoma. Now that's within the dura, so it's between the dura and the arachnoid mater. And the vulnerable vessels are the bridging vessels. So you have many vessels that go through it. These are bridging vessels. They drain the venous blood from the surface of the brain, and what happens is that these vessels, they get stretched and sheared. So that's the movement. You stretching vessels is not that big a problem, but if you shear them, such a sudden movement to the side, that opens them up. And the source of the bleed is venous, so therefore the growth of the hematoma will be smaller and slower. However, these can still become very quite bad because the patient may not deteriorate as much, but they might have slowly accumulating more and more blood. Now with the epidural hematoma, the blood has nowhere to go, So it pushes onto the brain. It pushes onto the dural, which pushes onto the brain. Whereas here, the blood itself pushes into the brain. And that can cause different imbalances in the gradients, and it can affect the impulses and all that sort of stuff. Now, finally, we go to something called an intracerebral hematoma. So this is bleeding that is deep within the substance of the brain. So it's the brain itself bleeding, rather than the meningeal spaces. And most commonly, it's the frontal or temporal lobes. And it can be such as a severe motion. So you have a sudden stop, or a contusion, which causes bleeding. Temporal hematomas are much more severe because that means that you have bleeding around the auditory and speech areas. And if it's especially on the left side, well, that can cause inability to speak or permanent damage, ischemic damage. So a summary: epidural space is in the epidural space. Epidural hematoma is in the epidural space. Anterior branch of middle meningeal artery, arterial bleed. Subdural is between the dura and the mater. It's the bridging vessels. They get short. They shear them, and the source of the blood is venous. And intracerebral is deep within the substance, and it's a severe motion during contusion or head injury, damages the brain, and it's the damage to the brain that causes this bleed. So this next question is a two-part question. So the first part is explain what effect the increasing volume of the hematoma has on intracranial pressure. And sometimes they ask you to draw a graph to illustrate your answer. Now this can be quite a tricky question. What they're asking you to talk about is something called the Monro-Kelly principle. And since and the total marks of this question will be under 4 marks, so you need to include 8 points, which get a half mark each. Sometimes you may want to draw a graph and maybe of use, depends on the question. I think this is a good example where a graph would be useful. And this is what the graph looks like. So the principle here is that our brain or our skull is a fixed space. So let's say when we have bleeding in our bellies or we have ascites, the belly can expand. There's a certain expandability because it's not surrounded by bone. That's not the case in the brain. So as the intracranial pressure rises, right, it increases with the intracranial volume. Now the volume can increase and increase, but the pressure will have minimal change. And the reason for this is because we have a sort of limit to how much the intracranial pressure can change. Because if it changes too much, well then we have affects our perfusion, and that's not good. So the Monro-Kelly principle here says that the intracranial pressure will be maintained as the volume expands. And the reason it does this is because the brain has something called compliance. It's the ability to maintain this intracranial pressure by compensation because of the fixed points in the sutures of the brain. Now, blood that can sort of move, or contents that can move, is your CSF and your venous volume. So what happens is that you get this compensation where if the intracranial pressure is normal, but the intracranial volume of the mass, so this could be a tumor, this could be blood, increases. So you have less CSF and less venous volume, therefore the brain can maintain the expansion. But we reach a point where the mass becomes too big, and this is where we suddenly have an exponential increase in intracranial pressure, where the amount of CSF and venous volume the drainage cannot increase. Now arterial volume remains the same because you need that for perfusion. But if we have too much, if all the available venous volume is gone and all the CSF capacity to use is gone, well then we have decompensation, and this roughly occurs at 100 milliliters. And intracranial pressure will increase suddenly exponentially. And this is where patients start feeling unwell, coning, and they can suddenly go under. Now if you have an epidural hematoma, this happens very quickly, and that's bad. The subdural happens a bit slower, but you still have to monitor it. Now the second part of the question, state the possible consequence of an increasing mass hematoma. So our cerebral perfusion pressure calculated by the difference in the mean arterial pressure, so that's the one in your blood, and the intracranial pressure. So what this means is that the intracranial pressure has to be lower so that the pressure gradient ensures that the blood goes from your bloodstream to your brain. Now, if our MAP, if our pressure starts to become equal to our intracranial pressure, meaning that our intracranial pressure increases to the point that it matches our own blood pressure, well, then the pressure gradient is altered and you have decreased cerebral perfusion. Consequence of this is hypoxia, which is bad, but what's even worse is ischemia. And ischemia means that the brain is not receiving enough blood, and that can lead to secondary brain injury. So overall, the brain has an ability to compensate for increases in intracranial volume by reducing its contents of the venous volume and CSF. This reaches a point roughly around 100 milliliters for the mass, and then the intracranial pressure increases exponentially, and this is where you need immediate intervention to drain the mass. And the result of this is that the pressure gradient is altered, blood is not perfusing the brain, therefore you get hypoxia and eventually ischemia. So the takeaway for this is that you need to combine multiple things. You need to combine your understanding of anatomy, combine your understanding sort of physiology, but this is mostly an anatomy question, and then show the understanding that, okay, the brain is fixed at its sutures, and therefore there has to be a sort of limit to how much pressure, how much volume it can take without changing the pressure. So you remember this sort of graph. I found this to be a useful picture for the Monroe-Kelly principle. But yeah, this sort of explains why hematoma is bad for you. Oh yeah, and if you have any questions about this, just put it into the chat or into anything else. So moving onwards, we have labeled the following structures. So we have a picture like this, and we have to label it. So what we have to look out for here is that A would be our lateral ventricle, so this would be a hollow area, and we can tell this by it being close to B, which is the head of the caudate nucleus, this little comma shape. Moving onwards, we have E. So E here would be something called the internal capsule, which is where the motor and sensory fibers go through, and they go all the fibers for one side. Looking at C, it's obviously the putamen, so the putamen is the bigger one on the outside. Then we have D, which is right here, and that's the external capsule. So internal capsule, external capsule runs right that way. And F, this is the thalamus. So what this comes from is putamen is here, globus pallidus is right underneath it. Thalamus is there, and slightly above it would be your, slightly below that would be the substantia nigra. The caudate always on top, and the internal capsule just goes through. So this is one of the final questions here. So we have a neurological examination of a patient which shows that Mr. X has paralysis of his lower face, tongue, and upper limb on the left side, but he's able to move his left lower limb. What is the most likely explanation for this? So this is where we finally talk about the human homunculus. So the brain is organized as such, and so he seems to have suffered a stroke. So his lower left face is paralyzed. But his upper limb on the left side he's able to move, but his lower left limb is able to move, but not his upper limb. Well, this is because of the different blood supplies of the brain. So if you have paresthesia and paralysis on the of the face, you can start suspecting the middle meningeal artery, because the middle meningeal artery supplies the middle part of the brain. So that's your post-central and pre-central gyrus, and that innervates your arms, hands, face, and tongue. Now the trunk, leg, foot, and genitals, that's by the anterior. So if you can think about the brain, it's just the top half of the brain, that's by the anterior cerebral artery. The posterior cerebral artery is more to do with the inside, so that would be your Diencephalon. Now a stroke, the MCA, would be the lateral aspect of the cerebrum, would include the areas of the lower face, tongue, and upper limb. So this way, he can't move his arm, he can't feel his face, but he can still move his leg. So the likely areas affected would be paralysis lower face, tongue, left side, but he's still able to move his left lower limb. Now, if it was a stroke of the right internal capsule, the patient here wouldn't be able to move his left lower limb either, because the internal capsule contains all the sensory and motor information from the whole part of that brain, so from that whole hemisphere. So it's likely that if he can't feel his left side, that it's the right side that's affected. And the reason it's the right side is because the corticospinal pathways, they decussate to a contralateral side. So the full answer for this would be middle cerebral artery stroke, which affected the fact that he has his face, arm, and hand, but lower limb is still intact, and it's on the right side because of the decussation. Now, if his left lower limb was affected, there would be a right internal capsule stroke. And if it was just his leg, then that would be an anterior part. Now we also have to be careful, because if it's on if it was his right side that was paralyzed, and he had his Broca's or Wernicke's area affected, then he would be unable to speak, because the left side is where you have your speech, for the vast majority of people, your speech and your ability to recognize speech and communicate speech. So that's what would have happened on that side. Therefore, so number 6, what we ask here is you have to look at the sides that are affected, picture the human homunculus, and I always would draw like a diagram like this when they ask the question, and you would see legs on top, arm, hand, face, and then you have a posterior cerebral artery. So that's all I've got to say here. I know it was quite a long session, and we went through a lot of different concepts, and some concepts are quite tricky. I know that some of the topics, like the substantia nigra, the basal ganglia, it was quite brief. That's because otherwise the video would be too long and too imprecise. If you want me to make a video on basal ganglia and Parkinson's, I can do that. We can look at the different pathways, how they interconnect, and how that sort of is a pathology in Parkinson's. Do let me know, and I hope this was useful. If you do have any questions, you can either email the society. I'll put a link in the description and also in the comment. If you have any other questions, just comment on the video. I have it set such that I'll see the comments first before anyone else. So don't feel free to comment as much as you want. It will be anonymous. But yeah, I hope this was useful. We will be sending a feedback form and to let us know how much, if we can improve. If you liked it, if it was helpful, give it a like, subscribe for more, all that stuff. And if you have any questions, just let me know. Right then, no further questions. We will be posting, like I said, feedback form and everything on website, on Facebook. So, subscribe, stay tuned, and you'll see what topics we're going to do next. All the video should be available within 24 hours, and that shouldn't be a problem there. All right, thank you for watching. Have a nice day.